So I'm Courtney Asenka. I'm your host for today. I'm a licensed mental health counselor. I'm a author with Hatherleigh and a CEU course creator content with Hatherleigh, as well as a life coach for student athletes. So today we have a very special expert guest, Dr. Jenneffer Pulapaka. She is a Board Certified Diplomate of the American College of Lifestyle Medicine and leader in holistic and preventative care. So welcome, Dr. Pulapaka. Thank you for being here. If you would like to give us a little overview and introduction of yourself, and then we'll get right into lifestyle medicine and how that can help a lot of our clientele.
Perfect. Good morning, everyone. So I am Dr. Jenneffer Pulapaka. I'm really the pioneer of podiatric lifestyle medicine. My journey into food as medicine began probably around 2012. We had a very successful restaurant, and I needed a way to bridge my professional career with my evening career of the restaurant. And I work with the James Beard Foundation, and this is right when food as medicine started taking a hold here in the United States. So I spent some time, went to DeLand, talked to them about their programs, and then over the next several years, I decided to become board certified in lifestyle medicine. I am the first podiatrist, and I think currently still the only podiatrist who has passed the physician certification. So I am a diplomat in lifestyle medicine with that board. I also hold 3 other boards. All 3 are in wound care. So this is how lifestyle medicine really works well for my practice. I have retired from my surgical board. I was surgically trained. I did 3 years of a surgical residency. I also did my fellowship in trauma reconstruction in Russia at the Elizarov Institute. But for me, I just needed a way to have a happy balance as a provider and not always look at my patients as, do you want pills or do you want surgery? For me, that wasn't a good way to continue my practice. And I've been practicing since I left my fellowship. I opened up my own practice in 2005. So I'm coming up on 20 years being in private practice. I have never been involved in a large group, or I have not been a hospital physician either. I've always been independent. And I think that's what's helped me and my practice and my team in particular not have burnout. So burnout is another factor with healthcare providers that is a serious issue. So when I look at satisfaction, lifestyle medicine was able to provide a good balance of that for both me and my staff and my team.
Thank you. Impressive background. We're happy to have you here. Can you tell us a little bit about how would you define, lifestyle medicine, and how is it different than the conventional approaches to health?
Lifestyle medicine is really taking the patient and having them be an active participant. So conventional medicine, I still practice conventional medicine. I still do surgeries, I still do prescriptions, but in conventional medicine, patients are a recipient of the information or the treatment plan, and they're not an active participant. When they would go to a provider, the provider would see them, make a diagnosis, construct a care plan, and then usually give a patient a medication or surgery. In lifestyle medicine now, patients are active participants in their care. I do utilize all aspects of lifestyle medicine. So we use nutrition, exercise, sleep, social connections, stress, and reducing inappropriate behaviors. That's kind of, originally it was always smoking and drugs, and now that's kind of expanded to be a little bit broader on that side. But there are really key things that I work with my patients to make sure they're all taken care of. When they come to my practice, the difference is compared to, let's say, another podiatry practice is they always say, well, why are we asking so many questions? Why are you asking about sleep? Why do you ask about my exercise or my fitness? Why are you asking me about my social connections? We even have on our form food security questions that I think are important. It's been important. It's been an important topic for me for years. And then we try to decide, how are any of the deficiencies in any of those areas impacting a patient, and how do we work to kind of regain or get back some health in that area? I'm frequently writing prescriptions for patients to practice better sleep hygiene. I frequently write prescriptions for patients to visit Medicare providers, dentists that practice in sleep medicine, so that if they have a CPAP machine that they're not using and they haven't been using, and I have a wound care patient that I think we have a real deficit in sleep, I write the prescriptions off and they can get an oral application for their mouth to help improve their sleep, which for me, I want you to sleep because that is the time that you're going to be turning on all your growth hormones. So that is when your cortisol levels drop off and then your growth hormones kick in for you to heal a wound and do repair. That's its biggest thing, is nighttime repair. So when I have patients who come to me and say, well, I just don't have time to sleep, I'm like, you don't not have time to sleep. So yeah, I'm wearing my devices. I don't think these two kind of overlap for me. So I'm kind of on the wall about the rings still, but I do use my information, and I work with patients on simpler formats for them to understand how to get their information that's out there. Both young patients and my older patients. So we work a balance on both sides, and that is with sleep. Within lifestyle medicine for fitness, my practice recently launched a chapter with Walk with the Docs. That's a national or international program. And we use every third Monday of the month, we get together with our patients. It doesn't even have to be related to our patients. Their friends, their family, their children can come out. We bridge over social connections. So we actually use a cemetery for our patients to participate and walk with the doc. Couple reasons. We actually tie in, it's the oldest historical cemetery in Volusia County. So we get to tie in a little bit of history, and we theme out a topic every month. But also it's a safe environment for our patients to walk. Our older cemetery, we have some nice hills to go up and down to traverse. And on the newer part of the cemetery, they have an area where they can walk safely in a straight level. So we actually have 3 different groups. We have our runners, we have our medium walkers, and then we also have our slow walkers, or our patients who can come, use a wheelchair, use their walkers. So that's that. Because I also want to tie in social connections. We ask that question frequently in our exam room. And when patients are in social isolation, that's equivalent to smoking 10 cigarettes a day. So that's pretty profound for me. And a lot of my patients, as we get older, they start to socially isolate themselves. And now we find when they participate in programs like Walk with a Doc, or when we have small group exams in the office around culinary coaching, we'll talk about that when that comes up. It's a good point for them to make connections with patients who are experiencing that problem that they are, whether it is peripheral arterial disease with PAD, how am I overcoming it? What are my therapeutic markers? How am I controlling it with diet? How am I working it with exercise? I can't do that exercise. They'll start to talk about, well, I do this exercise and I'm able to compensate. That's what I really enjoy about that. So having a more comprehensive practice I think is really important. And I will say one thing, lifestyle medicine has brought me back to a point where I am chronically finding ways to take my education a little bit further. I just completed the Blackburn course in obesity with Harvard. That was a long course. That was about 65 credit hours for the course. On that course with Harvard, I really enjoyed because it had, for each of my 5 days, I had another about 5 hours clipped onto each day that I can take. And, I hit that whole swath. And I think emerging yourself into these courses sometimes is really good. It really helps keep continuity as you're moving through with care plans as a physician on how am I going to incorporate it? What does it look like? What are my barriers? How did my colleagues face barriers? How did they coach a patient? How do we negotiate on items like that? And for me, when it comes to obesity, one of my areas that I work with is patients with obesity have so many, aside from diabetes and PAD, cardiovascular disease, I have osteoarthritis. I have tendonitis and arthropathies that really kick in. And sometimes we're not addressing those with our patients. We're, saying, sorry, you had multiple stress fractures. Sorry, you have multiple bouts of tendonitis or joint pain. And we're really not getting them a good way out. So my practice had to look at it and say, how do I handle my patients better? And how do I be a better physician? And how do I answer their problems when they're saying their primary cares don't want to address that issue?
And I think you bring up good points because, as clinicians too, we ask sometimes on the intake those questions about, the pillars of health and the exercise and sleep, but sometimes we don't really go into it. And I think now people are wanting more of that holistic care. And even though it's not necessarily new research, I think people are really beginning to appreciate how every aspect of their life affects another one. And I know I work a lot with teenagers, and a lot of times we say, okay, if you're not getting the sleep that you need, nothing we do in the office is going to help the emotional regulation if you're not getting, those core values and principles, met, before we work on other things. So from your perspective, how do you see lifestyle medicine helping with mental health issues?
When we first started asking questions from a lifestyle medicine standpoint, I was told initially, make sure you have resources to outsource your patient, because once you ask and that patient comes up, you need to be able to direct them to a caregiver that can provide that. So we did that initially. So that's, if it's new to you about asking questions and being comfortable, first speak with someone in your community that you say, all right, if I've identified these patients with the problem, how do I make my referral? How do I transfer? So some of the questions that we get even in our system is when we ask about my EMR system, I use Practice Fusion. One of the questions that starts in when we initially address patients on their intake form, or every so often we refresh on that. The question was, I feel like grabbing my office manager and saying, how does it go? It goes something like this. Have you ever been abused or sexually assaulted by a spouse or a former partner? When I first heard that question, it immediately flagged me that there was a problem with the question. It wasn't the fact we were asking it, it was the fact that it isolated it to their partner. So I told my staff, you're going to take out that line and you're just going to say, by anyone. And then my older patients, 85 plus, every now and then they'll chuckle, and then we always bring it back to them. I've had 80-year-old patients pause so long over those questions and think about it that now it requires us, if they're in a facility, to talk with the facility that there may be senior abuse going on in the facility. So opening up those questions, you have to know how to resource your patients out to a good resource that they're comfortable with. So we use that a lot. So it's not just for kids when we have my providers that I want to recommend them to. I also work with my patients that have PTSD. We'll find that it's really not being handled with their primary care. I'm going to get it, especially on a wound care side. If I get it, it's really important for me. We have really good studies that looked at wound care, and they would compare families that were going through emotional stress and abuse on heal time with other patients, and it does decrease wound healing, and it does delay wound healing on our patients. When it comes to safety, I think it's really important that when I have younger adults, 18 to 21, that don't know how to identify with their gender or what they're comfortable with, that I have mental health providers that provide them a safe environment for a discussion or a group that they can participate in. So that's how being, even though it's podiatry or they're coming in for an ingrown toenail or a fracture or a torn tendon, and when we ask that, we still have to realize that medicine is your practice, not your specialty, does not take place in a vacuum. You have to see the patient as a whole patient.
Mm-hmm. And I think sometimes we want to get into those, pillars of health with our clients, but right, sometimes, we're not a nutritionist or a sleep expert, so we don't really know how to best help them. So working with, do you have any tips on working with other behavioral health care providers? How can we collaborate our care, a little bit better? And what strategies would you, have for that?
Well, first of all, find out what you have in your area on that side. That's as a non-behavior provider. So I needed to look at different outsources for different care based on age, based on insurance availability. Those are all key things when I have to source out my referrals. Having good communication with the behavioral therapist is really important for me, because my team and my staff has to be able to communicate really well with them and find out, is that a good connection that we think is it going to be made with that patient? Or what are some of the obstacles or barriers? Some behavioral therapists are only online. Well, a lot of my older patients, sometimes that's just a real battle. I know we all want to do virtual, but boy, I'm telling you, my onboarding for my staff, when I have my patients, it just becomes hard for them to onboard virtually. So we also have to have, with behavioral specialists, places that are physical locations for patients to go to. And sometimes that is difficult. And also sometimes insurance is not going to cover it. So do they have the ability for out-of-pocket expenses? Do you know if any of your larger groups with some of your older populations, are there other programs such as YMCA has programs here that we can refer to them when we need just some maybe social support? Silver Sneakers is a really good place if I think I'm dealing with social isolation, that I can send off a patient to. That's in my Medicare programs. Those are important. If there's universities around, they usually have behavioral therapy programs that patients can become part of. And then sometimes the patients don't want to. So at times they will give us some recommendations back. Then when the patients come into us, we try to mitigate and work with the care plan that someone else may be recommending as we're trying to get it taken care of for them.
Okay. Let's get into some more of the plant-based food, and we were reading through your book. Can you tell us?
Oh yeah,
it's a great. You tell us a little bit more about how we can use food as medicine, and any kind of case studies you've seen where, our dietary choices have affected, our mental health, our physical health, and how that kind of adds into the whole holistic view.
So on plant-based medicine, for me and my practice, one of the biggest areas that I'm going to cover is one, cardiovascular disease in patients with PAD. That's my target group on that side. Number 2 is my diabetic patients. Number 3 kind of gets into my patients with renal disease and gout. And then I get into autoimmune arthropathies such as rheumatoid. And then I'll even move into osteoarthritis about that time. Each of those we kind of move differently when I talk about food and nutrition. When it comes to my peripheral arterial disease, my PAD patients that are isolated by themselves, when I use a plant-based diet, they always try to challenge and ask me, well, does it have to be plant-based? And I usually always retort back and say, well, clearly you've been eating not plant-based, and we're kind of in a situation that we are right now. So I use plant-based for all that I'm going to do or work with my patients. In doing that, I'm going to use a cardiovascular friendly diet, which is really low fat as much as possible. I try to tell them to eliminate free fats. That's what we do in the book. We eliminate free fats and salt. But for me, when they ask what are free fats, and I usually try to tell them, I'm like, that's the oils that you would see added in as you're cooking or preparing your food. So when everyone thinks olive oil is great and wonderful, well, it can be. It has some good benefits and then not so good benefits. On that side, it's usually the fat content is really high. That is a calorie dense area. And when we start to coach our patients, we realize that they have no idea how much oil they're using in their food when they're preparing it. They see things on TV and they want to saute it up, but they are just liberally using oil as if it was water when they're preparing their food. So that is a free fat that we try to reduce. Hidden fats that we have to watch with our patients. Avocados are not, they're high, but it's not used so much. It's my nuts that my patients really seem to gravitate towards that can really add up. One of my patients was really high. He's my PAD patient. He's missing on his statins. We're still not able to get him therapeutic on his statins when we're checking his lipid panel. And I found out that he's going through one of those tins of peanuts, probably about 3 a week, but they're salt-free. I'm like, good for you. But clearly the amount of fat that he was consuming was more than his body could handle. And I'll usually find those markers that come in. So that's how I start to coach with them on plant-based. One of the biggest barriers that I get is, well, what am I going to eat? I got it just the other day on my patient. When I was working him with his cardiovascular friendly diet, I said, well, we really need to reduce these things because he had decided he was going to try the keto diet. That didn't work. We really have a lipid panel that's out of control. His cardiovascular team is really upset with his panel and how he's progressing. And for me, I'm starting to see gout that crept in because that high protein diet now is kicking in with his kidney function. When I deal with any of my patients, I usually, if we've got a lot of comorbidities, I pull in a nutritional consult. So I'm going to go based on their recommendations. I work with nutritional counselors that know I'm plant-based, because like I said, my patients clearly know how to use meats. We're trying to learn a healthier way that doesn't involve that. So we're going to focus on grains and beans, things like that. Those are my two I think my most difficult areas that we experience in patient coaching of where they're deficient. They are, one, scared to death of beans. They're terrified of them. In grains, they can't name more than 3, and I'm pushing 3. I'd say 2. So we're very limited. So we have handouts, we have worksheets that we go through them on what grains are and what beans are. And that's when we use small group exams. We do a lot of those in my office where we will get together with food. I will usually prepare the food for my patients, and then they'll see and experience different foods to know which each one tastes like. I don't know. Maybe someone can help me out with why everyone's terrified of beans. And I keep on telling them, if you bought a pack of beans and you didn't like it, in that preparation, you spent like $4 on your pack and you only used a quarter of it. Okay, you lost $1.50. You know, I don't know what the fear is on beans. And grains is they just have, I think we've lost the ability to teach healthy living or get back to what we were doing 100 years ago. And so we have no concept of, you know, if I was to say farro to someone, they would have no idea. Couscous always gets pulled in as a grain. I'm like, no, you're back to pasta, so it doesn't count. But those are the plant-based problems that we have. I will say one thing. I can't overlook the fact that most patients really do not go out and get into an open air market. The way I got one, hold on, I got a handout right here. All right, so this is one of my classes on this side. All right, so the way I kind of break down when we do culinary coaching is, I don't know if is it showing? Let's see where my camera is. No, you can't see it.
Yeah.
Okay, so these are cards that I give my patients. It's broken up global, regional. The next one is grains. The next one's protein. And then we have a primary veg. Okay, so the patients will get 4 of these cards, and I'll make them work through a grid after we've gone through a couple of classes. So this is a handout. This is the kind of the way it looks when we do it that I did. And I'm kind of coaching with them on how they're going to do it. So for this, they picked on global region. I'll show you how it's important when we talk about veg. The global region was India. So I want them to think of a sauce that we're going to be composing on a global region. So on India, they picked turmeric, coconut oil, coriander seeds, cumin, fennel, and mustard seeds. Okay, so we designed a sauce or a chutney. Next, they picked barley, and then the protein was tofu, and then the primary veg was carrots. Next one was global, was Mediterranean. So we moved on that side with olives and lemons and basil, extra virgin olive oil. The grain was bulgur, protein was chickpeas, and the roasted vegetable was roasted tomatoes, and I gave them credit with roasted peppers too. Now we go down into Asian was one of the ones. So we got the Asian, they picked bulgur, and then the primary veg went water chestnuts, and then mushrooms. Now on the final region, they picked Mexico. So they designed that. We got down to primary veg, and you know what they said? What other vegetables are there? I mean, I was shocked and horrified that we just named a few. Maybe a few overlapped, but we got into 4, and they're asking what a primary vegetable was, what they couldn't think. So on the next one, I went out to, we have a really good open air Mexican market by my practice. I took one of my staff, and she videotaped me shopping through the Mexican market and what I was picking out and the signs and how we did it. And all I did for that day, the next day, was, it was really basic. I roasted everything. I massaged it with pepper and olive oil, and I roasted them, and then they had raw and roasted. And that was their time to experience food in a simple way. They kept on asking, like they had, I did just roasted beets on that side. I didn't get the beet greens, which I would love from a cardiovascular healthy diet, but beets are really great, and I love them for my PAD patients. But we had beets, and all I did was roast them. And then when they ate that just by itself with nothing on it, that was kind of eye-opening for them. So that's what it means to be culinary coaching with food when it comes to patients. I think that's important.
I think you've brought up some really good points where, we start with, the education of it. And a lot of times people don't necessarily know what they should eat or shouldn't be eating, or they've read that this is really good for them, even though it might not be great, individually for them. So I think, right, the education part is the first part. A lot of times with our clients too, we know that they're not eating as well as they could, and they're not sleeping as much as they should, or exercising. So even sometimes when they have that knowledge, though, we still find a lot of resistance to any kind of lifestyle change. How do you get your clients to really, and I think,
food is personal. Food is very personal.
Right, and everyone has a different view of it, has a different history with food too. Your, thoughts, or if you have any case studies on how to best help that resistant client who is very stuck in their ways or doesn't have all of the knowledge or resources that other people might.
One of the biggest factors is, one, you have to know your patient's A lot of them have ethnic backgrounds and they have family style or cultural dishes they want to keep. Number two is, do they have the support within their family? And what does that mean? That means I have a wife who has maybe uncontrolled diabetes, but I have a husband who's going to be a non-negotiator for her to get to a better health pedestal. So that's a barrier that we have to work with and usually bring them in if we're going to challenge that with why I'm the partner, the children, the older parents that they're taking care of. Why are they putting a burden on the patient when that patient needs a healthier option? I don't think the family members really see it that way when they're in that situation. So it's working with that team and saying, all right, do you understand why we're making this request? Do you think it's important for your mother to make it to the graduation of your daughter? Put a big goal out there on that side. I usually like to set goals for my patients, giving them things to go for and giving that family, having that family buy into that we want to see. I want to see, I want to see, my granddaughter who just got married. I want to see, maybe in the next 5 years, if I have, a great grandbaby, something like that, goals like that are out there that the whole family then understands the value in really good lifestyle changes. I negotiate a lot. So when we do things like these worksheets, I'm usually asking for them, we'll follow up on a month. I'm asking them to kind of recreate or start to add in 1 or 2 changes a week. That's about it. I mean, that's really it. Once they get clipping at a good rate and they're confident, then we're good. I use confidence scales all the time and I negotiate that with the patient. Let's say, okay, all right, Courtney, so you want to make a change and you want to incorporate more beans. So I'm going to make a recommendation that you substitute out meat during lunch and add in beans instead, whether you're doing hummus or you're doing plain beans. Is that something you think you're able to do?
Right. So you start small and
and you answer me yes or no. Are you vegetarian? Are you vegan?
I have actually been a vegetarian since I was 12. And
Okay, so I'm going to go vegan on you then. All right, so I'm going
I
to
was a vegan
negotiate.
for a little bit, but I feel for you because there's so many misconceptions and people are like, how do you get your protein? And oh, all you can eat are beans. And it's like, it's not that way. And I liked in your book, it said that healthy food, I'm not quoting it correctly, but it's not flavorless. Like it can have a lot of flavor. And I think once people understand that, it's like a cycle. They're going to eat healthier, they're going to feel better, and then they're going to want to eat healthier. But yeah, it's getting people to buy in almost as a preventative thing than more of an intervention.
But I have to have them be comfortable at a level. So if I negotiate with you on how many times you're going to substitute out beans for eggs, you would normally do a preparation with eggs. I
Mhm.
want you to not, I want you to substitute out beans and maybe if it was a binder, use chia seeds or flax seeds together. Substitute out, and then I'm going to ask you, can we do it? Can we get it done twice a week for lunch? Is that possible? Yes or no, you'll give me the answer. And then my question is, what's your confidence scale? I've got 0, that's never happening, or 10, not a problem. So that's where I sit there and wait. And if I get anything back under an 8, I'm going to renegotiate the deal because I don't want them heading into this process and realizing, well, this is not for me. It's just a total failure. I rather them say, no, fine. We may get down to, okay, during the holiday meal,
Mm.
can we have, and I'll incorporate something new there. So I try to find that balance when I'm going to get that confidence at an 8, so that I can move forward. We can check it again and see how it is. I use my team and my staff to do phone call reminders. Hey, Ms. Jones, you said you were going to do these 2 things. How did that work out for you? If it's good for them, then we'll move them forward. If it's not, then I may request a follow-up with me to renegotiate how I want to handle improving their lifestyle changes, because they've already usually set a value-based goal as to why those things were important for them. So I need that goal to be there, and then I move on their confidence. And then, like I said, I talked about family, but I also stay really heavily based on culture. What's your family cooking like? What's your favorite dish? What was your favorite dish as a child? Do you have cultural dishes that you want to incorporate? Do you know how to use them? Bring in a recipe that you had and we'll knock it out and we'll make it a healthier version of those things. So those are things that I think help when it comes to food as medicine and how you look at it. I think the biggest barrier, though, is patients not seeing the grocery store food that's out there, or the wealth of food that's out there. Just really being very limited with what is in their refrigerator. There is a study that looked at college students after 5 or 10 years after being out of college. If you were to open up their refrigerator and open up their parents' refrigerator, how many of the same name brand products would you see in the refrigerator? Those are scary. So I always think about that. I always think about that in general, when I open up my fridge, I'm worried about stuff, oh God, is that cucumber going to go out before I ate it? Okay, I'm gonna chop it up and mix it into something. I don't really have product brands in there. I've got real food that's in there. So that's where that comes from.
Good. Andrew, would you like to jump in?
Oh, thank you so much, Courtney and Dr. Pulapaka. It's a great presentation so far. I am actually a big fan of beans, just to let you know. And I thought it would be wonderful to bring in the co-author of your book, because it's unique to have a husband and wife together as partners in healthy living. And so Hari, why don't you unmute and just join in, and maybe you could tell us a little bit about sort of how the two of you work together as partners in creating the Heart Healthy Plant-Based Cookbook. I would just welcome that.
Sure, thank you. Good morning, everyone. I'll be very brief because this is about Dr. Jenneffer Pulapaka, not Hari Pulapaka. But thank you, Andrew. Very quickly, I'm a chef. I'm also an academic. And so Jenneffer and I will have been married 19 years next week, in fact, Monday. So we've been together for some time, and I mostly cook all of the meals at the house. Jenneffer makes me breakfast every morning. So when we got this opportunity to write this book with Andrew and his team at Hatherleigh, of course, we were incredibly excited because we're both on the same page when it comes to food. I grew up a vegetarian in India. I was a vegetarian for 21 years. And then I sort of fell off the wagon when I came to the United States as a graduate student, out of not having options and eating out of convenience, but I've kind of come full circle. At home, I cook almost exclusively plant-based. Every now and then there may be a hint of cheese on a pizza because we feel like splurging. So the ingredients were not a challenge at all because we're on the same page with that. It was more for me to understand what and how I cook will benefit one's heart, right? So the science and the medicine is something that I had some general knowledge about, but every time I thought of a dish or a recipe, I would lean to Jenneffer and say, hey, I'm thinking of this dish. It's good, it tastes good, but how can I make it heart healthy? How can I make it taste good? Of course, we agreed to it was initially a small shock for me to say no salt and no free fats. As a chef, that's kind of, you might as well take my knife away. But I learned very quickly that that's not the end of the world. I did some reading, I did some research of my own of what that would look like, and understood that there were some alternatives to creating flavor and umami and big bold experiences on the palate. So anyway, long story short, the way we came up with the book is, Jenneffer leads the book with her medicine and her lifestyle medicine tips. And then I sort of come behind that with the food and the recipes, but every recipe has a heart healthy note. And that's another unique aspect of the book. Usually my recipes have an introductory note about the food and my inspiration for the dish, but that made way for something far more important. That's the heart healthy note. And so in that heart healthy note, a reader gets to see, okay, there's a reason why this dish, which typically might have, say, onions, has a different kind of member of the lily family instead. Why is that? Because that alternative provides much greater heart health support than, say, the onion does. So I hope that's answering your question, but that's sort of how we wrote the book.
No, that's fantastic. I also want to take another quick moment to introduce a fellow collaborator, Marie-Annick Cotier, who is a prolific cookbook author and is also doing food coaching. Is that right, Marie-Annick?
Andrew, thank you for this introduction. I very much appreciate it. Yes, I have been doing this for more than 25 years and have helped thousands of people and work with a lot of wellness entrepreneurs to bring a better lifestyle and healthier eating through their communities. I have launched as well a high school healthy cooking competition, which is spreading all over through the US now. So yes, we're doing our work. We're trying really hard to help and change habits, and it takes a long time. And the final result is really up to every individual. It's not us, the professional. It's up to the individual to decide to change and to do what is right for themselves.
Beautiful. Thank you so much, Chef Marie.
You're welcome.
Was there a question or a comment, Jenneffer?
Mm-mm.
Okay, Courtney.
Very well said. And I think we're all starting to realize, like I said before, the benefits of, that holistic care and food as medicine. And sometimes even in my practice, I hear, well, healthy food is expensive, or I don't have the time to cook, or it's easier to just do that. And really it's changing that mindset and realizing, you have to look at it long term, that maybe it's a little more expensive right now for certain things, although I'm not even sure if that's true anymore. Long term, you won't be on certain, medications. You'll have a better quality of life. And I think we have to look at it that way rather than just the immediate, instant gratification of, sugary food or junk food or whatever it might be.
Yeah, sorry, some of the studies that are coming out right now are it's really concerning with regards to ultra processed foods that are out there and the engineering behind that. We could do a whole lecture on food insecurity, food deserts, sarcopenia, obesity. Patients who have obesity that are nutritionally starved. And that's a factor with what we see out in their environment. So, I mean, one of the latest studies came out and said now they're looking at MRIs after they eat an ultra processed food to see, are they getting a good enough dopamine hit on that product, or how do they want to revamp a product to make it more addictive for a patient? One thing I am seeing from my patients who are on the semaglutides, on that and tirzepatide, they are noticing that it does curb their appetite, or this drive that they had to be going for that thing or that product for satisfaction. So they really seem to be helping with satiety and satiation. So.
And one thing in the book it said, I'm going to read it, so that in the US, a person dies every 36 seconds from cardiovascular disease, and 80% of heart disease in the world could be prevented. If you think about that, and easily prevented in a way, we have this information now, so it's making those lifestyle choices and using food as medicine. And I think the more, and I applaud you guys for kind of getting all the knowledge out there. I think the more we know, the better we can do. And hopefully, by like what you're doing with the negotiating with the clients and checking in with them and the confidence scales, it really helps them feel, I think, more in control over their, lifestyle choices. And we know once people feel more in control, their anxiety goes down, their depression goes down, and they kind of have this buy-in to it. And then it is that, cycle that just keeps making them feel better. And then they make, healthier choices.
Hari, when he cooks, his food is off the chart. But I am so proud at what he does now, which is he will do something that he used to do years ago in the restaurant and modify it into a healthier version. The other day we were watching one of these celebrity chefs cooking on TV, and he's like, watch this. We watched him pour so much oil, just copiously into the pan. It was about a quarter a cup of oil. He was making I don't know, what was it? Was it a risotto? No, it was he said it was a healthy dish. I'm watching the amount of liberal oil just to saute the vegetables. God, Hari, what was it?
It was chickpeas. It was just chickpeas.
Okay, right. Okay. Oh, yeah, like a chickpea ragu. He finishes it off with like a third of the bottle on top after I kept on thinking that it had to be about a third of the bottle that you were using. And then he's promoting it as a healthy food. But then my patients and the public are clearly seeing misinformation coming at them. Clearly, one meal or one bowl should not have a third cup of olive oil in it. And that's when patients are always shocked, I think, when I'm like, don't 2 tablespoons? No, I want you to barely massage your vegetables with olive oil. So yeah, I think we got to work better being out in public and saying what is healthy, what does it look like, why do we crave that much oil or fat, why do we crave meat, how do we cook a majority of the food better? The best alternative would be for them is to have most of their meals be plant-based, and when they want to splurge or indulge, they can go back and have that holiday turkey that they wanted, because the rest of the time they were being good, and they may find out that it's not really worth doing that anymore. It didn't provide anything better compared to the rest of my meals that I've been having.
What would be like a starter shopping list guide for individuals that want to start eating more heart healthy?
I'm gonna always start off with beans and grains, going out there and picking those. I do like them to use both dry and both canned. If they're going to use canned, even though they say low sodium, we're always going to rinse them. I think those being staples are really good for my patients. Starting to use more spices, learn how to get your citrus, your lemons, your limes. Hari's going to help me out with what I'm missing. Pepper. Those are important, but learning about, thyme and rosemary, but the real ones, not the dried, but if that's what you have, then use your dried options. Learning how to bloom them in a pan. Those are really important. Interesting thing, you can use white wine. When you cook with it, you will burn off the alcohol, but it does add more of acidity. I'm a vinegar junkie. So for my salt, I'm always going to use vinegar. And I like the really specific, I use golden balsamic vinegar, and I get it from a specific place. But I go through copious amounts. But on legumes, beans, I think those are my big staples. Having enough variety, and then having enough raw vegetable in your pantry that says, maybe I want to do a ragu on top of a potato. Maybe I want to do a cold salad on the bottom, and I want to do stir-fried vegetables on top with beans. Maybe I want to learn how to season my grains. I try to get them, they're going to use rice, we try to use wild rice or brown rice. If they've got blacks or reds, that's great. I try to get away from white rice. I prefer bulgur and barley. Those usually you can find fairly easy. Everyone knows quinoa. My other staple is farro. So those really grains, because those are things that they can bulk up and they can utilize fairly quick. They can think of, making a more chunky pasta sauce, and you can use that chunky pasta sauce that you make over top of really nice, like wilted spinach and grains. Those unique things can kick in for patients that they have to try to, tie it in together. Hari?
No, I think you've covered everything, Jenneffer. So that's it. I've thrown a few things in chat, but yeah.
We have one question about what's your, let's see, where did it go? What's your take on eating healthy, a little bit of healthy fatty fish?
Okay, a lot of my patients, as I talked about before, are CKD patient, chronic kidney disease patient. Usually they're going to have gout that goes along with it. I'm good with fish, but I'm still an advocate for sustainable seafood. I still use Seafood Watch as a reference. And just the other day, my patient was talking about grouper, and then I had to scream down the hall. You know, black and red grouper are red listed right now with Seafood Watch, so find an alternative. When it comes to my gout, my CKD patients, the reason I'm talking about it is my cold water fish, such as my salmon and my tuna, are higher in purine, so I usually steer them away to a warm water fish, you know, snapper. Can't really get good info on Dorado or Mahi Mahi. We're assuming based on its water that its purines are probably low, but or tilapia is a really good one. Don't
No.
always throw that fish away. We have a lot of patients who are in areas where they don't have access to fish to be able to get that. The other one is I just drew a blank on, we do get catfish in our areas on that. All those are usually farmed, but if we're using Seafood Watch as a good standoff as to where to be purchasing your fish from, how to be purchasing, is it line caught? Is it farm? Is that an acceptable farm? Are they practicing humane practices with seafood? Then I'm okay with that too. But Seafood Watch also looks for the human side. So a fish may be actual good, but they actually may be dealing in human trafficking on the backside of the fish. So Seafood Watch will kind of curtail them a little bit and say, no, it's not an acceptable fish. Or maybe it's a farmed product, but they're not controlling the quality in that farm product. So they'll get a pullback on that. So I try to pay attention to those. And I try to tell my patients how to get that information to look into it.
Okay, we had another question too. Are you familiar with the recent research on heating oil being linked to increased free radicals and cancer risk? There's some research study that found high temperatures cause cooking oil during heating, during antioxidant.
Yeah, so I believe you're probably referring to advanced glycated end products. So that is what makes the Maillard reaction. When you sear your steak on a grill, that beautiful crust that you get, that's a Maillard reaction. So advanced glycated end products, which are called AGEs, those are actually cumulative, like radiation. So other disease processes, diabetes, they'll start to accumulate those too through the process. But once you start to accumulate them, you do not reverse on them. So and that's about temperature. It's not about the thing. That's why French fries are not healthy, because we're using that high heat and oil to sear them, which gives me more advanced glycated and more AGEs on that side. So your seared meats, even your seared vegetables, those things, when we're talking about that high temperature food, grilling is another one. That's where we try to shy patients away. We try to use more moist cooking. You know, in a pan, you'll start maybe things going a little bit, but then you'll use your stocks, your vegetable stocks, maybe your white wine. You'll use those components to steam through the food and cook it. There's all sorts of research on the best way to preserve the most nutrients in cooking of vegetables. And I hate to say it, there's not an easy answer. Each vegetable seems to have a different best way to prepare it. And it's not all steamed or all microwaved or all baked or all roasted. It varies per product in its ability to retain its nutrients. So that's we can't kind of put a one for all in that one. But I think that's what we're referring to with cancer. And you know, 7, we're at 8, I think we're coming up to 9, 7 to 8 of the 10 leading causes of death are related to nutrition. As high as up to, research will pull, some of them say 35, but some of them pull as high as 70% of cancers are related to diet on that. So, you know, it's really, and when we talk about cancers, I got to throw in another aspect. Exercise is really important. There's a really good group called Moving Through Cancer, and it talks about exercise and reducing recurrence of cancer, such as breast cancer, with exercise. So that, lifestyle medicine isn't always sometimes just about food. It's about that whole compass that we're looking at and how we handle, sending our patients to walk with the doc.
Great. And we have a few minutes left, but I just wanted to ask, where do you see, the future of lifestyle medicine and plant-based eating going?
Well, if I'm looking at it from my board, American College of Lifestyle Medicine, the amount of new coming providers is exponential. And they are really happy with people coming on board with the education, wanting the information, wanting to learn more about sleep, exercise, nutrition, social connections, positive, happy life. How does that impact your patient care? So I'm seeing more providers wanting to go for that. And that's probably because they're getting the request from their patients. Hopefully patients are starting to understand that we need to make lifestyle changes. The Pinterest keto, balls of unhealthiness weren't really working for them. They tried it for 4 years and it still hasn't worked. So maybe we need to look into doing something healthy. As far as I can see, that's where it's coming. Sometimes it's really hard with my providers to really make a change because they're scared. They never got the education in medical school. It's still very deficient. So it has to be something that they are tracking, and they have to track it consistently and well. Like I said, I do a ton of coursework. Almost every year, I'm really hitting substantial courses at these major universities to provide the best knowledge I have to give to my patients. I think you have to stay on top of it. You have to stay on top of it.
Good. Well, thank you everyone for being here, and thank you to our expert speakers. It was a great discussion. I'd like to remind everyone and invite everyone to our next month's coffee and chat. It's with licensed marriage family therapist and author Madhornan Webster, and we'll be talking about transforming grief and disappointment into growth and healing. And that will be Thursday, August 21st at 11 a.m. Eastern Standard Time. And you guys can all follow us on Instagram, YouTube, and Facebook. Thank you, everybody.
Thank you, everyone.